So good afternoon all. Myself, Dr. Amit Chakrabarti, and I would be moderating this very important session, today's webinar. Dr. V.D. Sinha, Professor Visochi, and Professor Kate are our esteemed panelists for today. May I request Professor V.D. Sinha to give the opening remarks. Professor Sinha.
Thank you. Thank you. And on behalf of WFNS Neuro-rehabilitation and Reconstructive Neurosurgery Committee and AASNS Neurotrauma Committee, I welcome all esteemed speakers. Because of the COVID problem, the physical and hybrid meetings are not possible. So this webinar are the best platform to share our scientific knowledge and clinical experiences. I must give special thanks to our speaker, Dr. Laura from Italy, Dr. Pinar from Turkey, Dr. Anita from India, Dr. Simran from Turkey, Dr. Anila Darbar from Turkey, and Mirna from Indonesia. Because of some emergency, Dr. Hassan from Malaysia, she may not be joining. Our panelist is Dr. Kate Dumont from Australia, Visochi, and myself. And Dr. Amit Chakrabarti will moderate our webinar. He is a senior surgeon, neurosurgeon from my city. And I thank all the attendees on this webinar. And every speaker will be given 20 minutes for presentation and then discussion. And I hope more and more discussion so get more benefit from the speakers for our patient benefit finally. So can I request Amit to start the webinar? Dr. Amit, please.
Okay.
Thank you, Professor Sinha. Thank you, Professor Sinha. So we would be starting today's webinar. Our first speaker would be Dr. Pinar Akdemir. She is a senior neurosurgeon and she is currently working in the Department of Neurosurgery in Ankara City Hospital as the head of Pediatric Neurosurgery team in Child's Hospital Tower. She would be talking about the endoscopic transsphenoidal approaches for pediatric patients. Another one thing I would like to add is she is not just a master neurosurgeon, but she is also a brown belt in karate. Over to you, ma'am.
Thank you very much. Good afternoon, my dear colleagues. It's a great privilege for me to give that presentation in this meeting. And I want to thank to Professor Sinha for this opportunity. And this is Ankara City Hospital. And this one is the Children's Hospital Tower. There are another hospital here, the physiotherapy and another psychological diseases hospitals here. It's a very big center. Endoscopic endonasal approach is a surgical technique used for the resection of the skull-based tumors through the paranasal cavity. And it is performed by otolaryngologists and the neurosurgeons together. Before EEA, skull-based tumors were removed through an open craniotomy with the use of a microscope. An endoscopic approach via natural orifices allows for less tissue disruption, no external incisions, and less brain manipulation, to shorter hospital admission and quicker recoveries. It has been very well established in adult population, and there is small but yet growing literature based on this approach in pediatrics. Small nasal cavities and sinuses in young children and thus smaller surgical corridors pose challenges to the EAA surgeon. Literature says endoscopic approach can be safely performed and efficacious in children even under 6 years old. But the surgeons must consider whether age-dependent anatomical structures developed. There are reasons for the paucity of published experience with endoscopic approaches to lesions of the sellar region in pediatric patients. Tumors of the sellar region in pediatric patients are primarily craniopharyngiomas and pituitary adenomas, and they are relatively infrequent. Anatomic features of the piriform aperture and of the sphenoid sinus in pediatric patients restrict surgical indications for endoscopy. Tetrou et al. Demonstrated in a radioanatomic cross-sectional survey of pediatric patients that the width of the piriform aperture in patients under 7 years of age was significantly smaller than that in adults. Pneumatization of the sphenoid sinus is not complete until 10 years of age. Therefore, endonasal endoscopic approach may be generally excluded in patients younger than 7 years. There is a lack of dedicated surgical instrumentation for this approach, and most of the neurosurgeons who are experienced to operate craniopharyngiomas are trained mostly to do this via transcranial approaches with microscope. The age that is applied to definite pediatric has been reported inconsistently, with the upper age limit varying from the 16 to 20 years. It is important because, for example, pituitary adenoma is relatively rare in childhood, and the incidence extends through the 19 years, and you have been following the patient since from 15 or 16 years, and she came to 19 or 20 years to you, and you have to operate her or him. And what is the pediatric cellular regions? Craniopharyngiomas and hypophyseal adenomas are the most common pathologies in the cellular region in children, and approximately half of the patients presented with these two pathologies. The other pathologies were rhabdomyolysis, germinomas, fibrosysplasias, chordomas, and hypophysitis in this area. Extremely rare pathologies such as anterior located pontine cavernoma, dermoid cysts, and embryonal tumors can be observed in this area and can be operated using the endoscopic techniques in children. And now I want to explain how we are doing this approach with the case examples. As the most seen cellular tumor in pediatric population, let's start with craniopharyngioma. They are benign tumors originating from Röntgenbusch with a bimodal age distribution of 15 to 14 years and 50 to 75 years. Pediatric craniopharyngioma has an annual incidence of 5 per million and accounts for 6 to 13% of all pediatric intracranial tumors. Almost all pediatric craniopharyngiomas are of the adenomantinomatous type, and they are generally calcified and thus not only more difficult to resect, but also not responsive to medical therapy. Surgery for childhood craniopharyngiomas, however, associated with a perioperative mortality rate risk ranging from 0 to 16%, and neurological morbidity rate risk of 0 to 20%, and pituitary-related endocrinopathy risk of up to 100%. Hypothalamic obesity has been reported in as many as 70% of patients, and extended endoscopic transsphenoidal approach can be used mostly for recurrent tumors and mostly for the cellular tumors, in the cellular tumors for the craniopharyngiomas. And our preoperative preparation is standard. Just to remember this, magnetic resonance imaging and the paranasal sinus tomography were obtained preoperatively for all patients to make a pre-surgical plan with the otolaryngologist. And endocrinologists and then ophthalmologists evaluate patients before operation and follow for years. Each patient received prophylaxis with a third-generation cephalosporin intraoperatively under general anesthesia with orotracheal intubation. The patient was placed supine in neutral position. Some surgeons preferred the head tilted to the right shoulder, but I don't. It can be. We didn't routinely use Mayfield keys tripping skeletal head fixation unless neuronavigation was needed. Right suprapubic area was prepared for high rest of the fascia, fat, or muscle to repair skull base as needed. For a long time, I have not been using fascia lata because the amount of the fat and fascia needed closing the floor of cella is very small, and I don't want children or adolescents have a scar on the leg. And the nasal mucous membranes were decongested with the injection of adrenaline and epinephrine. Lidocaine and the epinephrine, and we also use the soft cottonoids with the diluted epinephrine. And just to remember the surgical technique again, we always prepare the both nasal passage. The procedure was performed with a 0-degree endoscope, 4 mm in diameter and 18 cm in length, and we have also the pediatric scope. The endoscope was routinely inserted into both nostrils. The middle turbinates were located and pushed laterally to gain more surgical room. And then the endoscope was angled upward about 1.5 centimeters to reach the sphenoid opening, a key anatomic landmark. The posterior nasal septum was dissected, and the anterior wall of the sphenoid sinus was opened widely, exceeding the sphenoid opening. After removal of the sphenoid sinus, septations and the cellular floor was opened with a high-speed microdrill. And this is our team. And we always started with the ENT. This is our, she is, and he is our otolaryngologist. They are the member of the skull-base team. And he is the resident of the neurosurgery. Neurosurgery residents are always in the operation from beginning till the end. And mostly he closes our patients because we want them to get used to small surgical corridors and to use and to get experience with the scope. When we get the floor of the cella, we'll take over the scopes, and we always both use nostrils. Sometimes there is 3 instruments and the scope inside. We work with 4 hands, and this is our skull-base team for neurosurgery, and she is the operating nurse. And you see here, we are putting the 4 hands inside the nostril, and this is a 5-year-old, 7-year-old girl, but with a developmental delay. She looks like 5 years old, very small. And now we are starting with the opening. Actually, we are evolving. I had worked other good ENT neurosurgeons in different hospitals, but I now see that the mucosa is not bleeding. They are very gentle, almost not using bipolar for not to damaging nasal mucosa. We are injecting the middle turbinate here, you see, and we are pushing it laterally to open the passage. Before, we had been excising at least one of the middle turbinates to enlarge our passage. Now we are not excising anything. We are not taking them out. And we always harvest the bone from the vomer or from the anterior wall of the sphenoid sinus. And you see the bones can be very thick even in children, and we drill the posterior part of the vomer here, and you see the septation inside the sphenoid sinus. And if we drill here, we can open the planum sphenoidale, and this is the floor of the cella. We are drilling too, and we are enlarging the opening with the kerosene rogers. You can open everywhere. Here is the planum sphenoidale. You can open here. You can enlarge all of your opening, even over the cavernous sinuses. There is no bleeding, nothing. Just be gentle, be careful, and that's all. And sorry. And inside the cella, what we are doing, after cruciate dural opening, tumor in the cella turcica was removed with a curette or with suction. Supracellular tumor often drops down into view due to cerebrospinal fluid pulsations and can be removed easily. After resection of the central portion of the tumor with 0-degree endoscope, a 30-degree and sometimes 45-degree endoscopes was used to detect and to remove residual tumor. The surgical cavity was filled with Surgicel and wait for control of bleeding and then removed. If an intraoperative CSF leak was confirmed or suspected, an autologous fat and fascicle graft was placed within the dural defects as an inlay graft, and the synthetic dural graft was applied as an overlay graft. This is a standard closing. We always placed bone pieces harvested from the anterior wall of the sphenoid sinus or vomer, or sometimes the posterior part of the septum, between the dural graft and the bone opening to close it totally or partially. Fibrin glue was applied over the static dura and the bone graft. Then the sphenoid sinus was filled with gel foam. Normally, we do not pack nasal cavity with pledgets unless the ENT surgeon recommends. And we are using very few patients. We are using external lumbar drainages, almost not. Now, I want to show you something before going inside the cell and the tumor endoscopically. That's why I am showing this patients. They are. This one is a 7-year-old boy. You are seeing the calcified cellular mass here, cellular and supracellular mass. You see, this is a craniopharyngioma. It is a huge mass extending till the aqueductus sylvius and causing a slight enlargement of the ventricles and filling the third ventricle. And you see here is the post-op. This patient is operated via the Transsphenoidal approach, and he is the total excision you are seeing. And this is another patient. This one is a 8-year-old boy, and has this part is calcified also in the tomography, and the MRI shows that this is extending the posterior part of the third ventricle, and they are big, cystic, and calcified adamantinomatous craniopharyngiomas, and he has a hydrocephalus too. And this is his post-op MRI. You are seeing that there is no, both of them has a gross total excision. And why I am showing this, you know, this is the pathological preparat of the pathological tissue of the first patient. Some of the cyst has already emptied, and this one is the part which came from the posterior part of the third ventricle. When I was learning to operate craniopharyngiomas, it was really very hard to find and to distinguish the tumor and arachnoid tumor between the tumor and arachnoid plane, which is crucial to achieve total excision. I mostly open and work through the lamina terminalis. It is a very small opening behind the optic chiasm for the posterior part of the tumor. And it was taking time and need more and more experience. If you think that the craniopharyngioma cases come to even well-known pediatric neurosurgery clinics, 2-3 cases per year. So it is hard to teach younger generation to distinguish this part. Then I realized that it is easier to teach. There is dissection planes via endoscopic approach. And now we are going to endoscopic approach. This is a 5-year-old female. She was very small because of developmental delay. She had visual disturbance and double vision for a month. Loss of vision on the right eye for a week. Got thyroid hormone and cortisol replacement before operation. You see here the calcified, cystic, huge mass here. And this is a MRI without contrast, and this is the MRI with contrast. And this is the operative video. So her opening is large, but we didn't make any extended opening. We are open the dura in a cruciate fashion, you see here. And now you are seeing the cystic fluid, this yellow-green oily cyst is emptying. And we continue to open the dura. And you see the calcified parts here. And we are taking out the tumor in the capsule in piecemeal fashion with curette. We are very patient in these operations. We are moving very slowly. We are taking one by one, piece by piece inside. You see here the calcified portion. And I am not doing this. You know, our younger generation has to learn. And you see, this is dura, and he is now dissecting the dura and the tumor plane. And they are thinking that this is the arachnoid. It is not. Here you see the tumor capsule, and he is continuing. And we are dissecting everywhere. We are going inside, going out. Now you are seeing the plane with the arachnoid and the tumor. The calcified part inside the tumor capsule. And now you will see much better. You see, this is our plane. So this is the meeting for the reconstructive surgery. So we are peeling here, dissecting here, and we are controlling all of the cellular and supracellular area. And now you will see. He saw that it is very attached, so he is dissecting. Changing the instruments. Oops. Okay. It's taking time. And you see the CSF is coming. He is dissecting it from the dura, he is dissecting it from the arachnoid. And sometimes he is taking all this out. And he will now peel it. You see, we are peeling it from the cistern, the arachnoid of the cistern. We are taking the capsule in a piecemeal fashion. Changing the instrument again, taking another dissector. You see, here, there is the capsule. Very thin, very delicate. And we are pushing the cistern inside, sometimes with the cotonoids. And you see, here is the capsule. We don't even open the arachnoid. If you want, you can. Sometimes, you see, it is coming. It is dissecting, and we are trying to hold the cistern inside. It can be open. If you want, you can open it intentionally. You see, here is still, it is open now. And under it, there are still the capsule. There is still this is the posterior part of the cella. There are still the tumor with the calcification. We are continuing to dissect. You see, here is the tumor again. And the whole part is coming down with the pulsation of the CSF. It is coming very gently, very delicate, you see. And really, it is not taking too much time. It is not. And there is there's a thick and a big capsule of the tumor. Okay. We are with the cotonoids, we are dissecting it, and we are taking this out. You see, it is coming. And I will show another. And her vision improved, thyroid hormone replacement, and minerin continues. And this is a 13-year-old female. She applied with nausea and vomiting for a month. You see her MRIs. There is a cellular mass extending the supracellular area. And this is another one. And this is her operating video. When we operate her opening is smaller than the other one, even. She is bigger, but opening is for the cell of the floor is smaller. And this seems like a pituitary adenoma, but it is not. It is a papillary type of craniopharyngioma. You see, we are, again, we are doing the same thing, the same. We dissect capsule very gently, we are very patient, we are working 4 hands, we are dissecting it again. First dissect, and then pull. And we never pull very hard, and we just try to see. We pull a little bit, then leave it and dissect. You can open the arachnoid. You can see the whole, you know, the whole anterior cerebral arteries, whole stalk, whole, if you can, whole pituitary. Actually, we are seeing the pituitary here, but and you can see the you know, optic chiasm and everything. But if you need it for this operation, you don't need. It is a craniopharyngioma, but it is okay. And dissect. Push with the cotonoids. Dissect. And sometimes we are, now he's taking this out, and you will now see that for the second part, there is the capsule here. Now it will peel over the arachnoid plane. You see, it is peeling over. There is CSF here. And we are putting some surgicals, and sometimes we are taking out, sometimes we are leaving, but mostly we don't like to leave inside. And she has a gross total excision, papillary craniopharyngioma, no hormone deficit, temporary diabetes insipidus, and this is surface top MRIs. And if we saw any CSF leak, we always put the fat inside, always. And this is a 19-year-old female. She has a pituitary adenoma. She get first MRI 1.5 years before.
Your time is up, Professor.
Sorry?
Your time is up, Professor. If you could finish soon.
I am okay.
Okay.
Should I? Okay. So this is her post-op control. Gross total excision. The tumor was very hard, attached firmly to the pituitary gland, even in children and adolescents. The tumors can be very thick. If you don't be careful, you can have that irregular enhancement and the post-op temporary diabetes insipidus. And I want to show just use of the different angle scopes. Videos are taking too longer time. So this is the photos. This is the 0 degree endoscope looking at the cellular globe. And here is the onodistal. Be careful about it, because this is the anatomical variation of the sphenoid sinus. There is no bone over the optic nerve, so you can hit the nerve with the instruments or suctions. This is the 0 degree again. This is onodistal, and this is the bone opening, and this is the dural opening, and this is the tumor. And this is the 30 degree endoscope looking at above, superior. This is optic chiasm. And again, this is 30 degree endoscope, and this is optic chiasm, this is stalk, this is pituitary gland, and this is still adenoma. And this is 45, and this is 45 degree endoscope, right lateral, and this is cavernous sinus, and there is still adenoma. And this is 45 degree endoscope. We are looking at inferior, and the pituitary gland is falling down actually with the pulsations. So we are holding it with the instruments and pushing it a little bit upward. So we are taking the whole adenoma just under the pituitary gland. And we should be careful about the different lesions in the cellular region for the pediatric patients. This is a 7-year-old girl applied with a headache and panhypopituitarism. MRI shows cellular mass and another cystic lesion enhanced in the pineal gland. And they made the LP, but the CSF was cleared. But again, they told that the oncologists and the neurosurgeons first thought that it is a germinoma, and the family didn't want any open operation, so they have sent the girl to us, and we operated her by endoscope. And there is abscess drainage, 3 weeks antibiotic therapy, and she has temporary DI, took growth hormone replacement therapy, and then it is stopped. She was diagnosed as chronolematic granulomatous diseases. 10 years follow-up of endocrinology and neurosurgery because of no change in the pineal cyst. And thyroid hormone replacement continues. So it is important to have the histological confirmation. This is another vaginal granulomatosis tissue. I opened this, but the sella floor was intact, and I don't want to open the sella because the whole nasal passage was very infected. Whole turbinates are lytic. So I leave it. I didn't open it. Just they gave an antibiotic therapy. This is 3 weeks after the antibiotic therapy. I didn't have any pathological confirmation here or something, but it resolved easily because of the vaginal granulomatosis diagnosis she has. But you see the inflammatory changes in the sphenoid sinus. So it is a very because of the granulomatosis. It is just be careful about the cellular lesions because of the thyroid hypophysitis and the chronic granulomatous diseases. So what is the conclusion? Endoscopic approaches in pediatric patients is easy and efficacious approach, especially when the sphenoid sinus is phenomatized. Recurrent operations can be done easily via the same route because we are always protecting the arachnoid planes in the first operation. It is important to be patient during the operation, dissect the tumor capsule well, and work with 4 hands. We don't use external lumbar drainage in most of the patients, and histopathological diagnosis is important in pediatric population. And this is the second largest cohort on the world with a series of 54 patients who underwent surgery using the endoscopic approach in 7-year period by Gökmen Kahiloğulları from Ankara University, Turkey. The patient age from 1 to 17-year-old, a total of 43 patients underwent surgery because of presence of tumor. And they said that they achieved the gross total excision in 77 of the patients. And this is a very good result. So we should be more brave to do endoscopic approaches, apply our knowledge and experience in adult patients to the pediatric patients. And this is our pediatric teams. They are residents. And here's the pediatric spine, and here's the cranial spine. And so thank you very much.
Thank you. Thank you, Dr. Pinar, for such a good presentation. And your fine and patient dissection is worth appreciating. We have one question for you how often you have to drill the plenum sphenoidal?
Actually, I have, as I told you that I have worked in different hospitals with different ENT surgeons, and because of this presentation, I checked in a pediatric population till the 19 years old actually, and I did 2 patients, and now I realized that one of them was not needed actually. It was the beginning of the craniopharyngiomas. I have already in pediatric population myself around 22, 23 patients. And so I drilled 2 of them. One of them was for the closing the CSF leakage. And to do this, I tried to find I don't know why, but I tried to find the leakage. Then I realized that it is a pneumatized it is the pneumatization of the, sorry, I couldn't remember the English. So it is the whole, Okay, this is not done intentionally, but I drilled it. So I saw the chiasm and the optic nerves, and I closed with the ENT, but I put the external lumbar drainage. So I came into for the closing of the CSF leakage. Then I made a bigger CSF leakage. So I closed it again.
Fine. Thank you. Thank you, Dr. Pinar. So before we move on to our next speaker, I have a request to all the speakers to please keep to the time limit of 20 minutes because we are having 7 to 8 speakers, and the attention span of the audience should continue. So my request is to keep it short and sweet. With this, we go on to our next speaker, Professor Laura Valentini. She is from Milan, Italy, and she would be talking about Calvarian defects reconstruction in children, the autologous bone splitting techniques. Over to you, ma'am.
Here I am. Thank you very much for the chance to present. And first of all, I introduce myself. I am a neurosurgeon working in Milan, and I started with adult neurosurgery, then I turned up to pediatric neurosurgery, and my field of experience is obviously hydrocephalus and cyst. Tetrarecord is my favorite malformation, Chiari and syringomyelia, and cranioplasty for craniosynostosis, also doing all kind of pediatric neurosurgery. About these topics, I wrote peer-reviewed papers, and I'm a member of the ESPN and ISPN society, which both societies already had a woman as a president, and I'm proud of it. I focused in, because I thought we had to speak about reconstruction. I focus on the topic of critical points of cranioplasty in the pediatric age. In the pediatric age, cranial defects larger than 2 centimeters tend progressively
to
to
see any
enlarge.
slides.
You cannot see.
No. Can you share your screen, please?
I also already. Yes, I shared my screen already. Yes, here I am. Okay, here it is. Do you see it?
And if you just go to
okay.
presentation, yes, that's good. If you just go to presentation view.
Yes. Okay.
Yeah,
here I
perfect.
am.
Perfect.
Okay, thank you. So my surgical experience, as I told you before, and focus on Chiari, malformation, and cranioplasty in craniosynostosis, tumor removal, and about the membership of our society. I focus on reconstruction, so I focus on critical points of cranial defects in children. Cranial defects which are larger than 2 centimeters tend progressively to enlarge with growth, favored by the pulsation of the cerebrospinal fluid. The autologous graft with rib and iliac bone carry the higher mobility of the donor sites and have an high risk of resorption. This same for alloplastic bone substitutes, which are prone to resorption as well. Synthetic material even worse because they are prone to resorption, become unstable and infected very frequently, and moreover, they are expensive. So we report our results with the autologous Calvarian split and bone cranioplasty in children with cranial defects for tumors or malformation. The malformation which need a cranial vault remodeling, in which we have the higher aesthetic request and the need to complete a bone gap, are firstly anterior plagiocephaly, which is maybe isolated or syndromic, and the finality of this surgery is cosmetical for the psychological impact of the fascial and orbital asymmetry, and functional because the orbital asymmetry takes to astigmatus, diplopia, and finally to suppression amblyopia. Secondary torticollis, and there is no really a functional problem on brain. As you may see, if the child is not operated enoughly early, he has a front orbital retrusion, a lateral head posture, and finally he develops a fascial twisting and a strabism. And this is an effect of the malformation, but is also a matter of time. As you may see, the fascial scoliosis here on the right. We perform since many years with the aid of our craniofacial surgeon, which I have to thank because we work together since more than 15 years. We started to do this cranial demolition and reconstruction with rigid fixation, and the focus is the overcorrection of the orbits to prevent the recurrence of the malformation with time. But how to close these gaps that we have on the side in which we have the advancement? Because as you may see, on the side of the advancement, we have a big gap because we have to make the overcorrection. We started with this bone graft, with the bone paste, but the cosmetical results was not so good. So we started to use duplicated Autologus bone. And to spare bone, we use piezo surgery, which is also good for splitting the bone, also in the very young, when we succeed splitting the bone in children younger than 1 year of age. As you may see here, the results are quite good in terms of cosmetic results, which is just after surgery. And these results are maintained after many years. And you may see the correction, if the operation is done sufficiently early, the perfect correction of the fascial twisting. It's the same girl than before. The same problem of aesthetic problem is we may found on trigonocephaly. In trigonocephaly, we have a small anterior fossa due to the precocious closure of the metopic bone. We have hypotaylorism, which is corrected by the same. We have the orbital rim correction with the front orbital bandeau, which is also, we have the enlargement of the orbits by this autologous graft. And then we perform in this case the fixation with resorbable plates because the recurrence of this kind of malformation is less frequent. But if we don't do very perfectly, you may see here the perfect correction of the hypotaylorism, the perfect correction of the frontal the frontal enlargement, but there is a problem which is about the pterynal fossa. You may have with time this how we call it bitemporal hollowing. How to avoid it? We started to use the autologous splitted bone also for this aim. You may see here the autologous splitted bone under the temporal muscle to perform a perfect reconstruction of the anterior fossa. And here is the results before surgery, just after surgery, at many years later. You may see that there is no temporal hollowing, bitemporal hollowing, thanks to the duplicated autologous bone. There are also some malformation, very rare malformation, like this case, a genetically determined megaforamina permania, in which the cranium doesn't close at all. And when a congenital defect, and if the baby grows with this large defect, we need to close it to prevent trauma injuries. And also in this case, we make an autologous bone closure using splitting bone from the parietal area. You may see here the splitted bone, which is positioned with resorbable plates to avoid the problems due to the pulsation. And it is used also for reconstruction of tumors, defects. Here is a rapidly growing eosinophilic granuloma in a 9-year-old baby girl. You may see the large erosion of the bone. We had also to enlarge it to take out all the lesion. And then we performed a graft from the other side and fix the graft with resorbable plates. And here is a long-term good results. Also for larger defects, this kind of reconstruction is better than other change of reconstruction. This is my last case I want to present. It is a rare case of melanocytic rapidly growing tumors. We had to take out all this huge tumor, and this huge tumor grows in a 3 months time in the very young baby. You may see how he was suffering for this. At 18 months, we had a large defect remaining, and we closed the large defect with cadaveric bone. And we had a very big problem because after 4 years, the entire bone was resorbed. You may see here the residual, and in a very large hole. So we had to perform a new reconstruction. Once again, we used the same bone from the baby. We had this large bone splitted from the Calvarian, contralateral Calvarian. We splitted the bone and we use it to close the defect. We fix with a rigid fixation to avoid the resorption due to the pulsation. And after 1 year, we took out the plates, and here is the results, a completely ossified with very good cosmetic results maintained a long time. So our conclusion is that in our pediatric experience, autologous cranioplasty with splitted bone and rigid fixation for cranial defects had no risk for resorption or infection, is safe and cheap, so is a safe and cheap solution. Also in the growing skull of the very young, we perform it before 1 year of age, is highly effective for reconstruction even larger cranial defects, obtains good cosmetical results. And now I'm here for your questions.
Thank you, Professor Valentini. That was fantastic. I have one question here. I think you did answer it, but Anila Dabar has asked, do you use resorbable plates?
We prefer to fix anytime because in children the pulsation of the cerebrospinal fluid is, in our opinion, the cause of the resorption of the bone. And when we have, we suppose we have an high force of pulsation, we put unresorbable titanium plates. And also when we need to counteract severe effects of the recurrency, like it is quite evident in anterior plagiocephaly. To avoid the recurrence, the genetic recurrence is quite important to have the rigid fixation. In other cases, we have less force against our bone, so we use resorbable plates. They give some salience after some irregularity for a couple of years, and then they are completely resorbed.
We have another question. I presume that they've asked which bone is highly preferred, but I assume they mean which part of the skull is it most preferred to remove the bone from for splitting.
When we have to do the cranial malformations, such as cranioplasty for anterior anterior malformation, craniosynostosis, we use the same bone we remove. When we have to perform other kind of remodeling, other kind of reconstruction, we use the parietal bone, because the parietal bone is the more safe and also often the more thick bone, so easy to split. We can split everything using the piezo surgery is a great aid for having splitting. But the more thick it is the bone, the easier is the splitting.
Thanks, Professor Valentini.
Can I ask one question? Madam, in large defect in pediatrics, do you use 3D technique for this implant?
Yes, we don't have trauma, but as you may see that in children, you don't have to leave the defect become larger, because if you leave a defect too many times, the pulsation will enlarge it. So the best thing is to do the reconstruction as soon as possible. That's our philosophy.
Thank you.
Okay, thank you.
Thank you.
Thank you. May I have just okay? May I have just a final observation, which
I
is
know what your final observation is going to be, and I'll give you an answer as well.
Okay. I prefer to present in scientific topics in a mixed female and male faculties. I don't like room for women. I came because I think it's good to have these meetings. Any meeting is good to meet and to learn from each other. But
yes.
I don't like very much this kind of things. And they forget me many things. And I would like to ask to all the females who are here, if they really think that this meeting for females are good and we need it.
So I would very much like to see at least the number of webinars that we have that had women in equal measure to the number of women neurosurgeons that they are asked to present. But the majority of the webinars that have been advertised, many of them by very leading institutions such as the AASNS and the EASNS, have webinars entirely composed of men without a single woman asked. So I did suggest to Professor Sinha that we could have more women involved in these neurotrauma. Now, he's very kindly gone ahead and created one all for women, but I'm pretty sure that from here on, we will perhaps be able to have a more equitable mix.
Okay. Thank you very much.
This will not become a habit.
Okay. Thank you very much.
On a lighter note, Professor Laura, I am still here moderating for you.
Thank you very much.
And I'm panelist here.
So moving on to our next speaker of the day, Professor Anita Jagatia. She is from New Delhi, India, and she is the professor of neurosurgery in JIPMER, New Delhi. She has done her fellowships in endovascular, cerebrovascular surgery, and also minimally invasive spine surgery. Interestingly, she holds the Limca Book of Records 2014 for removing the largest marble-like brain tumor in the field of medical sciences. Congratulations, ma'am, for that. Today, she will be talking about post-traumatic cerebrovascular injuries. Ma'am, over to you.
And thank you, Dr. Ahmed. And my screen is visible, presentation.
Yes, it is visible. Yes.
Yeah. And at the outset, I want to thank Professor Ket and Dr. Sinha to give me this opportunity. And of course, I agree with both the professors, like the previous professor and Dr. Ket also, that The women should not be segregated, and at the same time, it is that women should be involved more and more in the forum, in the general forum of the neurosurgical webinars or conferences. So coming on to the topic, the post-traumatic cerebrovascular injury. We all know that the extracranial and intracranial cerebrovascular structural defect can be caused by the injury to the head, neck, or even the chest, and they can be both blunt and penetrating. So vascular injuries account around 25% of the injuries which happen, which if we screen all the injuries carefully, we may find up to 25% of the patients having the vascular injuries. And out of that, less than 1% will result in intracranial aneurysm formation. And because why it is essential, because missed pseudoaneurysms, which usually happen after the trauma, if they miss, they can be life-threatening. So how do they happen? Rapid acceleration and deceleration of the neck against bony structures of the neck, and at the same time, movement of the brain and blood vessels against the bony structures can cause pseudoaneurysms of the internal carotid artery, and at the same time, fistulous communications. They can be irrelevant injuries, that is iatrogenic injuries, while performing the surgery in and around the internal carotid or the vertebral artery. They can be like tumors in vertebral arteries, like in CV junction anomalies, or either the bony anomalies or the tumors. And in the new addition in this is a catheter-induced, guiding catheter-induced injuries to the parent arteries, which can happen during the endovascular procedures. So we know that by the commonest presentation of the traumatic injuries, traumatic vascular injuries is the CCF, and how it happens when there is sudden increase in the intraluminal pressure of the ICA, and at the same time there is impingement of the distal part of the ICA with the bone. And so this sudden increase in the intraluminal pressure may cause leak in the lumen, and that may communicate with the cavernous sinus, leading to the CCF. So these are the cases which were performed over the last more than 1.5 decade in our institution, which involved all the cases ranging from 3 years to 65 years of the age, and of course the male dominance was there in the cases. Majority of cases were comprising of the carotid cavernous fistulas, around 70 cases, and few case reports which included CCF with cervical pseudoaneurysm, iatrogenic IC injuries while performing the pituitary surgeries, iatrogenic cervical IC injury, then vertebral artery injury in CV junction anomalies, dark aneurysm post-traumatic in a child. There were catheter-induced intimal flaps in 4 cases, and dissection of the artery while performing the endovascular procedure. So this was a child, 3-year-old child, who had a fall from height around 15 feet, and she had this fracture of the frontal bone along with that interhemispheric knee. She was not suspected of having any vascular anomaly, so she was discharged. But after 20 days of the discharge, she presented with a seizure and loss of consciousness. And this was a repeat scan which showed enlarged hematoma. So CT angio was performed, which was suggestive of darker aneurysm. These are the 2 distal ACAs, and this was a clipped darker aneurysm, and post-op no residual neck causing. This was published in a vascular journal. Then this was another lady, 18 years old lady, who had growth hormone secreting pituitary tumor. Transsphenoidal dissection was done. And by removing the nasal pack, we routinely used to put initially the nasal pack after the microscopic surgery, and this was microscopic surgery was performed. And by removing the nasal pack, she had fatal apoptosis. Performed the DSA, there was dissecting aneurysm of the cavernous IC. Since this was the young lady, we thought we'll avoid putting the stent. We just coiled this aneurysm without the assistance of the stent. And however, this lady had coil compaction, and we needed to perform the stent-assisted coiling. So you see, there's a one thing here. If the intimal flap, the dissecting aneurysms, they never go without either you need to occlude the artery or you need to repair the artery. That repair can happen only with a stent. And this was after a year, this was the MRI which was showing the occlusion of the aneurysm. This was another patient, 50-year-old man, who had a huge giant invasive pituitary adenoma. He was operated twice also. And when the PAC he had, after removal of the PAC, he had 2 episodes of nasal apoptosis. This was a DSA which was done with the PAC in seat, because after apoptosis, the nasal packing was done. And this was the DSA which was showing nothing but actually the right ICA, posterior communicating artery, which is the fetal type of posterior communicating artery. But when the PAC was removed on table, there was the big filling of the aneurysm, the safety type of aneurysm at the junction of PCOM and the PCA. So when you are suspecting any injury after surgery, transnasal, then you should do the DSA after removing the PAC. Just don't consider that after even that DSA is normal and you have not removed the PAC, that should not be considered normal. This was another child, 3-year-old child, who presented with a neck swelling, and somebody inadvertently thought that this is the cold lapses without palpating and thinking much that this could be something else. This child had pseudo aneurysms in the leg, and this child came to us with a big pressure bandage, and we did the DSA. There was dissecting aneurysm of the IC, and the IC was terminating into it. And since the vertebral artery was supplying the MCA territory of this side, we occluded this pseudo SAC using the just 2-3 drops of the NPCO, so it was economic as well. So there was one case, 26-year-old man who had vertebral artery injury while doing the instrumentation. And of course, sometimes you need to occlude the artery. You can see the CT angio before the surgery. You can afford to occlude this injured artery when the cross flow is good. This commonly happens when there is occipitalization of semen, which is usually associated with high riding vertebral artery. This was another man who had C1 fixation. It was referred to us from some other place, and you can also see that the screw is going through the foramen of the C2. And intraoperatively during the DSA, he had such a huge dissecting aneurysm of the vertebral artery at the level of C2. We occluded this by using the coils, and this was a good okay cross flow to the other side. This is a patient, the same patient, where after occluding the pseudo SAC, these 2 sutures were removed, which were left because they saw the differential bleed from the wound side, and this side was healed after a few days. So this was one more case, trauma, post-trauma, and he had features of CCF orbital features on angiogram. He had dual pathology, the CCF as well as cervical pseudoaneurysm. So first the CCF was treated, and thereafter a covered stent was put across in the cervical IC, as there is no branch in the cervical. This is the pre-op picture of the same patient and the post-op, the symptoms resolved. So we know the CCF are of 2 types mainly, high flow and low flow. They can be direct, they can be indirect. And we also know that this, according to Barrow's classification, the type 1 happens when there is communication between the IC and cavernous. Type 2, when there is branch of the IC and the cavernous. Type 3 or type C, when there is communication between the branch of the external carotid artery and the cavernous, and type 4 is between the branches of the internal and the external carotid arteries. So we have the classification Borden and Conard based on the venous drainage, but that is generalized for all kind of fistulous communication. So we propose the classification based on the venous drainage in cases of CSF, as we know that they can be venous drainage anterior, posterior, combined, or to the opposite cavernous sinus and the cortical venous. So the anterior means the drainage is happening to the both the ophthalmic vein, indirectly going to the fascia. Posterior is when it is going posterior, the petrosal sinus and the pterygoid plexus. And in this, it's drainage which is combined both anterior, posterior, This is combined, and when it is associated with cortical venous drainage. So this is a more complex type of venous drainage. So CCF is not only the communication between the artery and the vein. CCF is a disease which is related with the venous drainage also. What type of venous drainage it has? So this is another case where you have we can see the through the internal cavernous sinus communication to the opposite side. This is very complex type of CCF where there's more havoc kind of venous drainage. Through the internal cavernous sinus, there is communication to the opposite side as well. This is one more case where this is this communication to the opposite side, to the intercavernous sinus. So this is the case which is communication between the internal and external carotid branches. You see, CCF can be life-threatening. How? When there's cortical venous drainage, they can present as a hematoma, hemorrhages. So the clinical presentation of CCF is in the direct CCF, the majority of patients present with the proptosis and chemosis. Means there are mainly the orbital symptoms, which can be associated with the extraocular movement paralysis, and ICH or SH, which is very uncommon presentation. Indirect CCF can present as conjunctival infections, which can be wrongly treated as infected with conjunctivitis, and they can be insidious in nature, they can be chronic, and they may relapse also. Clinical findings depend upon the type of the drainage. When the drainage is anterior, the ophthalmic complaints are more. When the drainage is posterior, the tinnitus is more common. And when the drainage is both anterior and posterior, we find the mixed symptoms. So these are a few cases examples. This is a CCF with a bad orbital symptom presentation. This is another patient which is presenting very minor symptoms. These are the long duration orbital cases where there is risk to the vision also with the corneal opacities. So this is the case with the bilateral CCF. There is communication with between the two sinuses and both the bilateral sixth nerve passages. So what is the goal in the CCF? Occlusion of the fistula while preserving the parent artery preferably. Then majority of CCFs they are treated via the percutaneous transarterial route. Initially, we used to use the balloons frequently. Now, platinum coils is a gold standard which we are using. Then the stent can be placed across the fistula's communication. Transvenous access may sometimes be required through the supraophthalmic vein when the petrosal access is not available. So material, we can use all sort of materials can be used as we occlude any fistula's communication. So this is the case where the balloons were used. This is the communication which is showing, and after putting the balloons, this communication is gone. Again, one more case with the balloons. This is again one more case with the balloon. The only problem with the balloon that they can jump and run away from the right where you intend to put. This is one case of migration of the balloon. Another way of treating them is, of course, not now in this era. That you can trap the IC if the good cross flow is there. These are the few cases example of the balloon using we can see the balloon after in the plain X-ray also. So the coil is another option, a very safe option, which is and you don't need to occlude the. This is an incomplete treatment of the CCI where there's so many cortical veins draining, and this can be fatal. And as in this patient, it resulted in the occlusion of the distal flow. These are the CCF which can be occluded with a small coil or the glue, the NBCA. This was a low flow CCF which was treated by using the glue only, NBCA, the cheaper treatment, and this is post-op picture of this same patient. Another patient treated with a coil and the post-op recovery of the symptoms. So we did the study that we measured the intrafistular pressure of the CCF, and in the beginning the pressure was very high, and as we start deploying the coil, the pressure drastically decreases from 100 to 70 to 67. So this shows that even if you have done the loose packing, this CCF this fistulous communication will block with in due course of time on table. Within minutes, you can see that the CCF got blocked and it did not require so dense packing, which is usually required in aneurysm surgery. The same case again, one more case where we just waited for a few minutes and the CCF got up, the fistulous communication got up. So you don't require very dense packing in fistulous communication. These are the post-operative results of these patients. All the patients had orbital symptoms and which recovered drastically up to 85%. Proptosis also improved and in the tinnitus. The only thing which showed lesser improvement is in the ophthalmoplegia. So these are the orbital signs symptoms which improve. This is pre-op, this is post-op. Again, this is pre-op, this is post-op recovery of the orbital symptoms. Here we can see the complete, the extraocular movements, they are intact even after occluding the communication. So what the other type of injuries which we encounter nowadays with more and more endovascular procedures is the dissection of the. You can appreciate some intimal flap over here, some lifting of the intimal flap for the aneurysm in the ophthalmic artery, IC ophthalmic region, coiled nicely, but when we did the repeat DSA, because this patient deteriorated after coiling of some hours after coiling, and we saw that this flap, this lifted and bent into the dissection and complete occlusion of the ICA. Similarly, one more case, done FT for this case, for this ICA aneurysm, and there was intimal flap raising. So these kind of flaps should be carefully seen when one is performing the endovascular procedure. So this is one of the kind of iatrogenic injuries which we give to the cerebral circulation. So to conclude, commonest presentation of trauma-related cerebrovascular injuries is chronic CCF. Endovascular treatment is a mainstay of CCF in majority of post-traumatic vascular disease. And preferably, one should do the open surgery, especially in the children, where you can avoid the radiation exposure as well as a long-term follow-up in terms of DSAs or MRIs. Thank you for patient listening.
Thank you very much, Dr. Jagetia. I don't have any questions. I was wondering if Dr. Sinha, yes, Professor Sinha, you have a question?
Yeah, Anita, can I know for intracranial pseudoaneurysm, to clip or coil, how you decide?
Sir, it is mainly pseudoaneurysms. Actually, if they are the aneurysms which are in the cavernous region and the paraclinic, they are difficult to clip. Then the aneurysms which are distal PCAs and all, they are again difficult to clip because there you need to occlude the vessel if it is distal PCA. So it is opening the brain and doing such a big craniotomy, which is a very straight pathway, straight course of arteries also. We can directly occlude the artery. So it is endovascular is better. When the aneurysm is distal, like DACA and all, then it is better to clip because they are amenable to clipping and the surgical results are same as the endovascular procedures. But when it is in the vicinity, in the region of cavernous or paraclinic, it is always better to do the endovascular procedures, as the main idea is to heal the wall. Unless we heal the wall, it will not cure the disease. So you need to reconstruct the artery using this.
In our institute, we have big series of this aneurysm.
Yeah, I read it, sir.
So if there is a foreign body, we clip. If there is no foreign body, we try to do with coiling. This is our policy. Yeah.
We don't get direct trauma actually. We get the delayed trauma, sir.
Thank you, ma'am. So the next speaker, Dr. Duygu. She is from Istanbul, Turkey. She is a neurosurgeon at Professor Dr. İlhan Varank Training and Research Hospital, and she has been working there since 2019. She has many publications to her credit. Today, she would be talking about cranioplasty on functional basis. Dr. Duygu?
Yes, can you hear me?
Yes,
Yes.
yes, yes.
Okay. Dear colleagues and distinguished guests, I'm very pleased to be before you today, and I would like to express my thanks to everybody who has organized this webinar. Today, I will tell you cranioplasty on functional basis. First of all, before I begin, I would like to share with you the outline of my presentation. First of all, I begin with the definition of cranioplasty, and finally, we will conclude with case series. It is, as you all know, a well-known procedure in modern neurosurgery, and it is the repairing of skull wall defects. In this procedure, we insert an object such as bone or non-biological materials. It may also be defined as a full thickness reconstruction of Calvarian bone. With the help of it, we restore the integrity of skull, protect neural structures, and also improve the cerebral hemodynamics. The protection of the brain and its cosmetic aspects are the major indication of cranioplasty. Furthermore, cranioplasty is also a significant functional role, since it may improve the neurophysiological function and restore the normal aesthetics aspects of patient. This procedure gives relief to psychological drawbacks and increases social performance. As you are familiar with, we perform this procedure not only for cosmetic concerns or to protect the brain against external traumatic effects, but also to protect the brain dynamics against atmospheric pressure. After the compressive craniotomy, the single brain and scalp syndrome related with neurological deterioration is an uncommon condition. Following this procedure, there's a recovery in neurological and radiological imaging deficits. With the help of cranioplasty, we can avoid the recurrence of brain damage and also achieve the plastic effects. And this can protect the patient from cerebral seizures and relieve the syndrome of Trifine, which is also called a motor Trifine syndrome or sinking flap syndrome. If we come to its indication, we can talk about cosmetic restoration of external skull appearance and symmetry, and the relief of symptoms because of a craniotomy defect, and the protection from trauma such as blunt or penetrating in area of post-craniotomy or post-traumatic skull defect, and the reduction of irritation of the brain as a result of pressure on and deformity of the surface of the brain. The reducing of irritation may improve the seizure control if this is an issue. Also, the cognitive deficit may improve following cranioplasty, especially with large defects. The onset of symptoms may be delayed months to years after the craniotomy. As to its contraindication, there may be an infection, especially at the craniotomy site, but also at the distal sites due to the fear of seeing the cranioplasty flap, also brain protruding beyond the confines of the skull. Finally, untreated hydrocephalus, which is complicated because treating hydrocephalus may require repairing the bone defect, usually in combination with a shunt. As far as timing is concerned, when it comes to literature regarding the timing of cranioplasty after initial surgery, other than the replacement of autologous bone flaps, there are a few studies. Here we see bone resorption or aseptic osteonecrosis as the main complication in autologous cranioplasty. The existence of multiple confounders and heterogeneity in studies lead to the controversies on this matter. While going over the literature on this issue, I have encountered details telling that late cranioplasties were associated with aseptic osteonecrosis of the flap, whereas early cranioplasty increased the risk of osteonecrosis. Despite these findings, we can say that there are no firm conclusion on this association, and evidence regarding the difference between early and late cranioplasty is lacking. We choose the graphs and timing based on the cause of the initial injury. When patients are operated for traumatic brain injuries, it would be better to make cranioplasty using autologous flap for structural support and cosmesis. In patients with stroke, on the other hand, using custom-made PEEK implants in material of choice. In cases where the autologous bone flaps are not used, timing is less important, and other factors such as the patient age, cost, defect size, defect shape and complexity, skin availability, the need to repair cranioplasty's material availability and cosmesis should be taken into account. Now, briefly, I would like to go over the storage techniques. Here we have plenty of methods which focus on preservation of the bone flap and maintaining the sterile condition and or osteogenic capacity of the bone flap for later reconstruction in cranioplasty. Traditionally, the method of choice has been either cryopreservation, I mean storage of the bone flap at extremely low temperatures or in subcutaneous pockets in the abdomen. Here we can say that the risk of infection for both methods are the same. However, we can see the cryopreservation is the most commonly used method in the literature. And now the complication, we can basically talk about three main complications here, namely bone flap resorption, infection, and hydrocephalus. As for bone flap resorption, resorption of the bone flap, which is also called aseptic osteonecrosis, is a well-known complication following cranioplasty, particularly in the pediatric population. In this technique, we reoperate the patient and employ the synthetic graft as replacement, yet it may also be associated with the risk of bone resorption, including multiple fractures, bone fragmentation, larger defect size, a younger age, and the presence of ventriculoperitoneal shunt. Damage to the brain or unacceptable cosmetic properties for the patient may result from a large defect caused by bone flap resorption. Here again, we see controversies and conflicting results regarding the timing of cranioplasty and the storage methods used. To give an example to this, we can have a look at the study by Bauer et al. They retrospectively evaluated 54 pediatric patients who underwent cranioplasty after decompressive craniotomy. Based on the results of their study, they recommended that children who present with one of these risk factors be observed closely for any sign of bone flap resorption. In case of a bone flap resorption, using a synthetic material in a revision cranioplasty might give us an excellent alternative option. And now the infection, we see the risk of an infection following decompressive craniotomy or cranioplasty is ranging from 2.3% to 20%. Here, as an example to this range, we can take a look at the study of Wecking et al. They compared autologous cranioplasties with alloplastic cranioplasties in his review and found that the overall risk of infection was 5.6%. Again, in this study, however, depending on the materials used in cranioplasty, the risk of infection resulted in different rates. They found that autologous cranioplasty has the highest risk, that is 6.9%, and hydroxyapatite cranioplasty with 3.3% had the lowest risk of infection. In another study, bifrontal cranioplasty and bihemispheric or unilateral hemispheric cranioplasty were compared. As a result, a risk factor of 8.7% was found in patients subjected to bifrontal cranioplasty. And now I would like to tell you our last complication, hydrocephalus. Following the decompressive craniotomy in patients having cranioplasty, we can talk about many reasons that may cause hydrocephalus, including intraventricular hemorrhage, subarachnoid hemorrhage, or the decompressive craniotomy itself. In 2% to 29% of the patients, post-DC hydrocephalus was observed. We can mention two systematic reviews that relate the increased risk of hydrocephalus after early cranioplasty, and two systemic reviews show an increased risk of hydrocephalus after early cranioplasty when there is a pre-cranioplasty hydrocephalus. Therefore, a late cranioplasty in such cases may give more time for the spontaneous resolution of hydrocephalus. And now let's have a look at the cognitive function. There is an ongoing debate as to the effects of cranioplasty timing on cognitive function. Here, neurophysiological rehabilitation, the timing of surgery, surgical technique, and cognitive assessment tools are the confounding factors. By restoring cerebrospinal fluid, hydrodynamics, intracranial compliance, and cerebral blood flow, when the neurocognitive chains are at their highest level, early cranioplasty was found to improve cognitive function. Now I'd like to tell a meta-analysis by Zekola et al. They found that the best cognitive function is achieved between 3 and 6 months. 6 months if patients are undergoing neurophysiological rehabilitation. Hung et al. And Corolla et al. On the other hand, reported that the neurologic outcomes are not affected by the timing of cranioplasty. As you can see, different studies by different doctors reveal various confounding results. I'd like to share with you some case of cranioplasty, and thank to Professor Pınar Özışık because she provided us this case. In our first case, we have an 11-year-old male patient on whose head glass of a window fell down from the 11th floor. He had an open and partial skull fracture on the front temporal parietal and a brain laceration and was operated due to this. This reason of his survival was that he had this accident in the hospital yard because he was in a hospital environment. He was immediately intubated, had his CT taken and operated afterwards. The doctors performed the complex cranioplasty, and then in his follow-up, right internal carotid artery infarct developed. Due to a brain edema, the second incision did not show a primary wound healing. He had a serious wound carrying, and then he had a secondary wound healing. He had been hospitalized in the intensive care unit for months, and he had been under physical therapy at home in the last 8 months before applying to us. Later, he was hospitalized on October 2020 in Ankara in order to receive a better physiotherapy. And here before you are the CT imaging of the said patient taken at time of accident. As I have said before, in the right frontotemporal area, he had open partial fracture, and depending on the severity trauma, he had a parenchymal damage and accompanied by interhemispheric subdural hematoma. The patient was operated following these images. And here we have the post-op images of the patient. The patient had a wide right frontotemporal parietal craniectomy. As you can see in the images, together with a brain edema, a right internal carotid artery hemorrhagic infarct started to develop. However, another acute surgical intervention was not planned for him. And now, I would like to share a few videos with you about said patient. This video shows the first post-operative stable condition of the patients before the physiotherapy started. He had a very weak control over his head and body. He started a very intensive physiotherapy program. In this process, the mother was concerned a lot and she cared a lot and also helped him do a number of exercises during the day because she's a neurologist and she knew how to make the correct exercise very well. This video, this video image was taken on the same day as the previous one. As you can see here, the patient had no control over his body and head. He was unable to walk without the assistance of her mother. And these are another videos about him. We can see the development in child after a month of intensive physiotherapy in Ankara. He was able to walk with the help of a device and made some meaningful sound. Even though there was a slight neurological improvement, his treatment was not discontinued. And he was consulted by the neurosurgery department to see whether a cranioplasty could be made. However, due to the risk of infection, hydrocephalus, low skin healing, considering the secondary wound healing before, no one thought of performing a cranioplasty surgery. And then a year later, it was thought to be too late to make such an operation. In these photos, you can see the image of his head shape and skin incision. You can see here clearly the secondary improvement that I have mentioned. As you can see here, depending on the position of the head and because of the force of gravity, when the defect is too large, the parenchyma was protruded out and down, and this might lead to a traction injury. On December 2020, the patient was again consulted by the neurosurgery department. Upon his neurosurgical examination, the patient was quadriparetic, right side 3/5, the upper left extremity was 3/5, the other lower left was 3/5. He was able to stand up with the help of a long leg splint and verbally make meaningful sound and was just able to say mom and water. We also observed that patient had tachycardia of 110 beats per minute. And these are the MR images of the patient taken after he was consulted by us in November 2020. And these are the preoperative three-dimensional CT images of the patient taken after he was consulted by us. You can see wide decompressive craniectomy defect on the three-dimensional CT. This video was taken 3 days before his operation, though he had received physiotherapy for nearly 9.5 months in the hospital and at home. He had a slight neurological improvement. These images were taken following on the post-op 6 days. His cranioplasty was made with porous polyethylene. Hydrocephalus did not develop. The skin wound healing was quite well and no infection developed. The general condition of the patient was pretty good. And another videos. This video was taken 4 weeks after the operation. As you can see, the patient was able to move with a walker and assistance, but not a device. As you can see in this video, when a support is given to the patient from behind, he was able to walk better and in a rhythmical way. The patient now started to form sentences instead of single words. His tachycardia recovered as well. As seen in this case, it should never be said late in children. Cranioplasty should be applied immediately under suitable condition when such a patient is encountered. Now I'd like to share with you the second case, the 15-year-old female patient who had been injured due to bomb which exploded near her in Syria in 2017. A operation was made there. When we saw the patient in her neurological examination, her right side was hemiparetic 4/3/4/5, right side spastic. She had a severe headache. Here, as you see in the images, the doctor performed left parietal decompressive craniectomy and neuroplasty, and she had a hydrocephalus developed on the left ventricle posterior horn. As you can see, because the images were taken with the patient in lying position, the parenchyma has protruded out from the defects. If the patient were in a standing or sitting position, this would be not be cases. These are the post-op images. Her cranioplasty was made with acrylic material. Neurological examination of the patient was better than the beginning. For example, now her right side semiparesis has nearly recovered and her spasticity has decreased. Her severe headache disappeared. Now I'd like to share with you the last case. We have a 39 years old male patient who had a right middle cerebral artery hemorrhagic infarct for 1.5 years ago. The first operation of the patient, which included the compressive craniectomy and neuroplasty, was not performed in our hospital. In his follow-up, hydrocephalus developed, and in line with this, a ventricular peritoneal shunt operation was performed 2 months ago. Then the patient was admitted to a rehabilitation hospital for treatment, and he was consulted by the neurosurgery department to see whether there was a flap swelling and shunt dysfunction. And here before you are the three-dimensional CT images of this patient taken at the time of the consulting by our neurosurgery department. As you can see the images, the patient had a right temporoparietal craniectomy together with a flap swelling, a previously formed right middle cerebral artery infarct zone. In these pre-op MR images, the cystic and encephalomalacic areas can be seen. These images were taken following on the early post-op day. Cranioplasty and VP shunt revision were performed on the patient. Our cranioplasty was made with acrylic and programmable shunt was performed. Overall, we can say that the materials we use in the replacement of bone defects have evolved over time. It should be noted that when we select optimal materials, we should consider multiple factors such as the age of patient, the size and location of the defects, the choice of the surgeon, the primary reason for undergoing craniectomy. Besides, there are a number of storage methods described for cranioplasty in order to preserve the bone flaps and to maintaining their sterile condition, as well as their osteogenic capacity for later reconstruction. In sum, I can say that there are no defined guidelines for cranioplasty. However, I believe that this presentation may be a starting point for us to create a comprehensive guidelines by making a multi-central study and amazing our data. Thank you all for your attention and listening to me. That's all. Thank you.
Thank you much. Thank you very much, Dr. Seaman. We've recently changed in our hospital to largely use acrylic or materials because we had a much higher infection rate using the autologous bone. But of course, that is subject, of course, to cost restrictions. But the other thing that we have noticed is an increase in complications with late cranioplasty. So we've been aiming to do early cranioplasties wherever possible. I was wondering, what you thought was the optimal time to do a cranioplasty.
I read nearly all the review and literature. There is no consensus about it, but I saw that 3 or 6 months, nearly 6 months later, there is less infection and complication.
We've been aiming for 6 weeks.
6 months.
No, I understand. We've been aiming for 6 weeks though, to try and avoid the damage to the brain from the herniation. I think Prof. Pina might have a comment to make there. You've been nodding, I can see.
I agree with you. I am also thinking to do this as soon as possible when the edema is getting resolved. And we were planning in a national survey with Duygu because there are a lot of people who is doing the decompressive craniectomy because of a lot of reasons, trauma and etc. And everybody has really a very good experience, but the follow-up of patients are changing because the neurologists and the physiotherapists are mostly taking care of them. So we want to know what to do, but you are aiming 3 weeks, and I now in such a days because of the COVID, I am aiming less than 3 months now. Maybe we will get to the 3 weeks too. But I hope that actually I think that it is how much earlier is much better, I think.
I note that Dr. Daba has said in Pakistan they're aiming for 4 to 6 weeks.
I have another question, Kate, is about the methyl methacrylate instead of acrylic or the autologous bone. What do you think about that? And the other question is, what do you do when you have the problem of hydrocephalus and cranioplasty that had to be dealt together? In my experience, I usually do the cranioplasty first by removing the CSF through an EVD. And then if the hydrocephalus develops, then you put a VP shunt. But I want to know, Dr. Seaman, what's your experience about it?
I think I am the junior. I have really not much experience, but Professor Pınar's issue.
We have been working with the Duygu, so this is thing, we are first putting the cranioplasty, like you, Anila, and then if the hydrocephalus develops, we prefer to put the shunts. Why? Because mostly people, especially in Turkey, they put the shunt first. But if there is a big defect in the cranium, so I am thinking that it is affecting also the working of the shunt, because the this is open to the pressure, and the pressure inside the atmospheric pressure, and the pressure inside the head is changing when you are coughing, when you are lying down, when you are sitting, and so even if you put the programmable shunts, if you don't close first the craniotomy defect, so your shunt is not working very well. So this is the most common mistake the other people have made. So what we have done is we are always putting the cranioplasty first, and if we need it, we put the shunt first. And you have seen the Duygu's presentation that there are cystic enlargements and the ventricular enlargements of the patients. What we have been doing together is we first punction, make the punction during the operation, and we get the CSF, and mostly they are very, very low. It is a very low pressure, and we are sucking it very slowly. Then we replace the graft and we follow. That's all.
Thank you.
Just a comment from me. Just I want to comment in shortly.
One comment, Professor Sinha.
Okay.
Go ahead.
Okay. Shortly, we had a meeting in Naples in Italy, and under the guidance leadership of Dr. Ekrano. So we made the consensus about the cranioplasty, and it already been published in 2020 December in ACTA. So about the age, timing, and material. And Dr. Kat, I think you are right. 6 weeks is the earliest should be done until there is some contraindication. Another comment just I want to give, instead of external drain, we keep the lumbar drain and watch for few days. If patient is improving and no deterioration, then we remove the lumbar drain. Slowly we could close it, and we have very good results.
Yeah, yes. You're right. You're right.
Okay, thank you. Good discussion.
Yeah. Thank you. Thank you, Professor Sinha. Thank you, Dr. Duygu. So, moving on to the next speaker, Dr. Anila Darbar. She is from Multan in Pakistan. She is currently the medical director and senior consultant neurosurgeon at Mukhtar A. Sheikh Hospital in Multan. She also is an assistant professor of neurosurgery and program director for neurosurgery training at the Aga Khan University Hospital, Karachi, Pakistan. She is an avid speaker, not just in neurosurgery, but she talks on women's empowerment, and she is appreciated among many internationally. And another point which I would like to mention about her is her philanthropy and her charity work, especially the clinics which she does in Karachi. It's quite inspiring, ma'am. So today she will be talking about minimally invasive CT-guided endoscopic evacuation of large ICH. Over to you, ma'am. We are unable to hear you.
Can you hear me now?
Yes, ma'am.
Okay, sorry about that. I was just thanking the organizers, Dr. Sinha, you, Amit, and Dr. Kate Drummond for inviting me in this webinar. And so we are going to shift a little bit of gears, and we're going to talk about how the evacuation of large intracerebral hematoma through minimally invasive CT-guided endoscopic approach. So I work in 2 hospitals. This is one of them, which is in Multan. This is the Mukhtar Sheikh Hospital, but I'm also working in Aga Khan Hospital in Karachi, Pakistan. And the interesting part is that both the hospitals are about 500 kilometers apart. So I actually travel between both of them every 15 days. So the introduction, intracerebral hematoma accounts for about 20% of all type of strokes. The high morbidity and mortality is due to increased intracranial pressure, which is caused by the large volume of blood and secondary destruction of the brain parenchyma. The current treatment includes either best medical management if the hematoma is not large enough to cause life-threatening issues, versus surgery if there's too much intracranial pressure and the GCS is low. The common surgical practices include for ICH, large ICHs especially, is the decompressive craniectomy or decompressive craniectomy plus evacuation of ICH. I have seen some practice of only doing a decompressive craniectomy with the idea that the large hematoma will resolve on its own. But in my experience, I have found that when such a large hematoma resolves and increases the volume, it causes more pressure. Also, it causes very long ICU stay if you actually do not evacuate the ICH. So I usually prefer that if you are doing, if there's a large ICH, you should either do a decompressive craniectomy and evacuation of ICH if that's the preferred method at your institution. What an alternate method I am suggesting here, which actually alleviates doing a decompressive craniectomy, is actually doing a minimally invasive approach of removing this clot and observing for high intracranial pressure through an external ventricular drain. This, in my experience, have shortened the ICU stay because you actually remove the clot and you are measuring the intracranial pressure simultaneously with an EVD. And also you completely obviate the need of another surgery in which you have to go and do the cranioplasty for the decompression. Now, there have been a lot of literature out there, a lot done by Chinese and Japanese neurosurgeons in which, and these are two of the papers that I'm quoting here, in which they have done this kind of procedure that I'm going to talk about with good results. There are a meta-analysis of mostly a lot of papers who are doing this approach. And the one thing that usually comes out of them is that patient selection is actually quite important in this. The ICU stay is usually decreased when you do this kind of procedure. The functional outcome may or may not be different in the longer run. But the hospitalization is definitely shortened. And then there is this INVEST trial in which is a randomized trial in best medical management versus this minimally invasive approach using endoscopic surgery to evacuate the ICH is still going on. So this is a single center retrospective study in which 10 patients were there. The mean age was about 58. The pre-op GCS was 8, ranging somewhere from 4 to 13. None of them had any bleeding diathesis. The comorbids were hypertension in 5, diabetes in 6, smokers in 2, and ischemic heart disease in 2 patients. The mean volume of hematoma in this population was 52.9 ml. Mean surgery time was about 105 minutes. Mean hospital stay was 9 days, and complication was death in 1 patient due to rebleed and chest infection in 2 patients. These are the instruments that I use for this procedure. This is a tubular retractor system that's out there in the market, very easily available. And not only you can use this for removing the large ICH, but you can also use this for actually removing tumors as well. You need a 0 and a 30-degree scope. You need a suction adapter so that you can increase or decrease your suction depending if you are cornering at the hematoma and the normal brain parenchyma. And then you need some angle suction tips so that when you move these tubular retractors, you can actually take the clots out from different directions. This is another kind of tubular retractor system that's out there in the market. And the good thing about this is because of its pointed tip, it actually slides the brain instead of cutting it through. So it's actually a better way of entering into the clot because you will just slide the brain through with least damage to the functional tissue. And once you are in, then you remove this inside, and then you have this plastic tubing through which you can work. There's also this device that's out there, which is actually a suction tip. And you can see it's a very thin suction tip. You can easily insert it through this tubular retractor. And again, these are just fancy devices. You can just use a simple tubular retractor and suction, and that would also work. So the surgical technique is that you position the head in a Mayfield clamp, and the CT neuronavigation is registered. The shortest trajectory from the cortical surface to the hematoma is identified. A linear incision is made, and an approximate 2.5 centimeter craniotomy is performed. Dura is open in a cruciate shaped fashion. Sulcal opening is preferred, otherwise a small corticotomy is performed. Once that is done, once you have identified where your clot is through the neuronavigation and your area where you're going to introduce, the endoscope is first introduced under navigation guidance freehand, and the plastic sheath is then introduced in the same trajectory. And using combination of an endoscope, the straight and angle suction tips, the hematoma is evacuated. The plastic sheath can be easily angled sideways, superior to inferior and medial to lateral, to remove the clot. Now, the beauty of, you can actually also do this through a microscope. What the endoscope actually gives you a better view, a closer view. And because it's a short, the tube is longitudinal, the microscope light somehow never hits inside properly. So endoscope not only gives you better vision on the TV, on a screen, but also gives you enough light that you can actually see through the clot and distinguish between the clot and the functional brain parenchyma. And EVD is then always placed at the end of the procedure to monitor the ICP. So this is a cartoonic diagram in which you can see that there is a clot. You make a 2-point, first you introduce the endoscope, and then you introduce the sheath. And on the sheath, you start evacuating the hematoma. Here you can introduce your devices. You can use your suction, your endoscope, and then you can actually see that you can actually rotate it to remove the clot until normal brain parenchyma is seen. This is usually the view that you usually get. So as you can see, it's a very tubular view, and this is an endoscopic view you can see. I don't have a video for this, but this is the kind of the view that you would look. And as you can see that, looking through a microscope in this clot, it becomes quite difficult. So endoscope actually really helps. Now I'll be presenting the cases. So there's a 54-year-old gentleman with history of CVA, diabetes, hypertension, who came to the ER with sudden loss of consciousness. His initial GCS was 4/15. And we did an endoscopic minimally invasive procedure to remove his clot. Because of his low GCS, post-evacuation, he required a tracheostomy. And his hospital stay total was about 10 days. His GCS improved post-surgery, but he required quite extensive rehabilitation for recovery. This was the clot, and you can see that this is the trajectory that I've chosen to remove the clot, and it's a small opening. He was also hemiparetic before, and that's why required quite extensive rehabilitation. And this is just a few days later. You can see that I usually leave the EVD to measure the ICP so that you can actually monitor and treat the intracranial pressure if it arises, since you are not doing a decompressive craniectomy, and there's always a chance of brain swelling. Second case is a 28-year-old with history of cocaine abuse. His initial GCS was 8/15 with right hemiplegia. He had a large left PG bleed. Post-evacuation, his hospital stay was about 9 days, and on recent follow-up, his hemiparesis was improving. This is the pre-op and the post-op picture of his evacuation. My third case is a 78-year-old gentleman who had diabetes, hypertension, and Parkinson's, and who presented with a GCS of about 10/15. Now, this gentleman had a cerebellar ICH, and we also did the same procedure on him. And although he was old, his GCS, because his GCS was a little better and not 4 or 5, post-evacuation, he actually became awake and alert and started following commands, and his baseline dementia remained. He stayed in the hospital for 8 days, and I had just recently met him a week ago, and beside dementia, he is completely fine. And as you can see that this is a pre-op MRI of the gentleman with this large clot. This is a post-op CT with a small opening and evacuation of the hematoma. The next case is a 55-year-old who presented with a history of rollover road traffic accident with initial GCS of 9/15 with a large ICH, which improved post-surgery, and he did very well, and his hospital stay was 55 days. So as you can see, the GCS, as we have all learned through our residency program, that the initial GCS actually determines the history many a times. Patients do recover, but if the GCS is low, the recovery is usually prolonged. And this was the clot. And this was the craniectomy that was performed. Case number 5 was a 70-year-old with IHD, diabetes, hypertension with a left temporoparietal lobar bleed. His initial GCS was 11/15 and he improved post-surgery, and his hospital stay was about 8 days. And this was the large ICH that was removed, and you can see there's a small defect right there through which we had removed the intracerebral hematoma. So in conclusion, minimally invasive endoscopic removal of ICH is an alternative and equally effective procedure compared to a large decompressive craniotomy or craniectomy. It minimizes the operative injury, surgical time, and obviates the need of a future cranioplasty. It is a minimally invasive but maximally effective. And my next goal is that instead of CT guidance, I want to actually do an MRI and a DT so I can actually look into the white matter fiber tract. So when I'm deciding my trajectory, I know which is the trajectory which has the least functional fibers so that I can go through with it. Thank you so much.
Thank you, Dr. Daba. I'm just having a look if there's a question. So Dr. Chakrabarti has asked, do you feel that the hemostasis is easier with the sort of microsurgery that you're proposing?
Yes, it's actually not difficult. You know, your very thin bipolar can easily be introduced through this. The other thing you can do, usually Surgicel, Fibrillar, or any kind of hemostatic agent also works very well. Now remember, these are all the cases that I've shown had nobody was on any blood thinner medications, nobody had a bleeding diathesis. So removing this clot was much easier than somebody who is on Plavix or clopidogrel and who would have bled. I would have never performed this kind of procedure in them because I know that stopping the bleeding in those scenarios requires a much more, it won't be possible through this smaller opening.
My question would be, I think we would use an endoscopic or, you know, a micro, small mini craniotomy approach, particularly for the deep and basal ganglia hemorrhages, usually more a frontal approach to avoid, crossing any important white matter tract. So I'm not sure that you need tractography for that. But for some of the hematomas that you showed, they really came to the surface. And yes. So, you know, mini craniotomy with or without endoscopy, you know, it's quite easy to choose your trajectory.
Correct.
You really got to just take it where shortest distance between 2 points.
Yeah, correct. Absolutely. Yeah. So, you know, as I said, Kate, that the papers that are out there, the meta-analysis also always says that the patient selection is very important to do these kind of procedures. If you have to pass through a lot of large functional areas, then you will be actually damaging a lot of areas. So, for that, this is not possible. This is a very large ICHs which come to the surface, or in which you have to travel a very short distance to reach them, are the ideal cases to do this kind of procedures.
Oh, Dr. Jagita has a question.
Yeah, Dr. Darbar, very nice presentation. I just want to ask you, do you exclude any vascular malformation before performing this minimal invasive procedures? Because
yes, so when we do our CT guidance, we usually do a CTA simultaneously to make sure that there is no vascular, like an ABM or any other kind of abnormality within it.
Yeah, because these uncommon locations like temporal node, they can be very small area which may not be visible in CT angio.
Yeah.
Okay.
That's the only thing we do. We actually, when we are doing the CT guided neuronavigation protocol, we just add a CTA to it. That's all we do.
I think we should move on to our last speaker. But thank you so much.
Thank you.
Thank you. Thank you, ma'am. So we move on to the last speaker, Dr. Mirna Sobana. She is the former head of emergency department in Banjar Public Hospital. She is the neurosurgery lecturer in Padjan Jaram University, Bandung, Indonesia. She is also the secretary of neurological surgery department at Hasan Sadikin Hospital, Bandung, Indonesia. She is head of pediatric neurosurgery division of neurological surgery department of Hasan Sadikin Hospital, Bandung, Indonesia. She is the chairwoman of Indonesian Women in Neurosurgery. Welcome, ma'am. She will be talking about reconstruction of pediatric depressed fractures.
Thank you very much. I would like to share my screen.
Yes.
Sorry. Excuse me, have you seen my screen yet?
No, we cannot see your slide.
Sorry.
It says that you've started to share your screen, but we can't actually see any slides.
Okay. Hold on a minute. This must be, sorry. My files.
Maybe if you can again try to share the screen.
Okay. Can you see my slide?
No, I think you need to open your presentation before you start sharing your screen.
Yes, I already.
If you could switch off your video, maybe the internet connection is a bit slow.
Oh, okay. I switch off my video right now. Have you seen?
Not yet.
Not yet.
Not yet.
Not yet.
No,
oh,
not yet.
I already shared it. Sorry. It seems like my internet connection is not quite so good. I'm sorry. Can you hold on a minute?
You can leave once and rejoin, I think. That can work.
Okay, I will try to leave first and then I will try to rejoin. I will try once more. Is there any of my slide?
It just says that you've started to screen share, but we can only see black.
Oh, I will try to leave. I'm so sorry.
Yeah, I think it's some internet issues which you are facing. So maybe you can leave and then rejoin. So I suppose even the audio is off now.
Okay. We'll try to reshare my screen. Can you see it now?
Yes.
Yes.
I'm sorry, I have to turn off my video because of the lack of internet here. I would like to thank you, Professor Sinha and Professor Drummond, for inviting me to this wonderful webinar. My name is Mirna. I'm from the Hasan Sadikin Hospital, Pajajaran, and I'm a member of AASPN, Asian Australian Society of Pediatric Neurosurgery, and also I'm actively as reviewer in Child's Nervous System journal. I would like to present. Actually, I'm a pediatric neurosurgeon. Actually, trauma is not my major patient in my department for me, but since this webinar highlighted about trauma, neuro-rehabilitation and reconstruction, and then I will try to present about the depressed fracture and reconstruction in pediatric patients. Depressed fracture is a break in the cranial bone or crushed portion of depressed fracture result in the bone of skull fold being folded or depressed inward into the parenchyma, cerebral parenchyma. It is usually a result of high energy impact to the skull. Usually it's blunt trauma. It could be this simple ping pong or depressed, and it could be the depressed fracture could be closed or even open depressed fracture. In the closed depressed fracture, we can observe the patient for a few days or waiting for if the patient is in the rural area, so it could be have a few times to refer to neurosurgical center. If it's open depressed fracture, it has to be an emergency treatment here because it's prone to be infection. From depressed fractures, depressed skull fracture account 7 to 10% of children that admitted to hospital in head injury, and 15 to 25 children with skull fracture. And compound fracture cause more brain laceration than the simple fracture. And from Professor Ersahin et al., he classified the depressed skull fracture into the true skull fracture, depressed skull fracture, and then flat skull fracture and ping pong ball. The most cases is true is 88%, and after that ping pong ball 8%. The cause of injury would be most of it is because of fall and traffic accident, and boys is 67%, and girls 33%. It's from 1 day to 16 years old, but it's appear to be equals for the first 3 years of life. And the symptom and sign, usually we found the loss of consciousness at the time of injury, nausea, headache, hemiparesis, seizure, comatose, and another one is just less symptom and sign. And infection rate is range from 2.5% to 10%. And usually replacing the bone fragments, it's only for the clean wounds or closed depressed fracture. If there is dural tear and CSF leakage, it should be repaired, and antibiotics usually used in patients with compound fractures and mostly in open depressed fracture. Ping pong ball depressed fracture usually found in neonates and infants. It's an inward buckling of the calvarium, and there's some report that the ping pong ball depressed fracture is found to be spontaneous since birth. And then it's another one, simple depressed fracture. It's open, and here we can see the depress of the skull. In the bone window, we can see it clearly in the bone window. There's the table externa, and is placed under the internal table of the another part of bone of in the side of the depressed fracture. Here is the sample of it, and then compound depressed fracture usually has laceration surrounding the tissue area, usually damaged, may overlay the bone spicules, and it's characterized by full thickness scalp laceration and usually extensive tissue destruction from the compressive bones. And this is our example case of the boy that falling from the height. It's a slight opening of the scalp, and then here is the depressed fracture, and we can see it in the CT scan, and it seems like no other brain hemorrhage or intracranial hemorrhage under it. We have to do CT scan to see whether there's a brain hemorrhage or another damage, or maybe epidural hematome or dural laceration or subdural hemorrhage or even intracerebral hemorrhage. And from the earlier age, depressed skull fracture in neonates is we can find it's spontaneous, but it's very rare. It's ranging from 1/4,000 to 1/10,000. It because of delivery trauma or abdomen trauma of the mother during pregnancy can be cause of depressed fracture. So the depressed skull fracture in ping pong, I mean this usually in ping pong ball fracture can be found intrauterine. Sometimes it's unknown cause, but usually it's because abdominal trauma, or the trauma happened in within delivery because of using forceps, or the mother have a fundal pressure because of the lengthening of the birth, I don't know in English, but and In neonatal injury, usually accident or usually child abuse. The spontaneous ping pong ball or depressed fracture in neonate, in some case with unknown cause been reported, but it's might be the promontory of the sacrum is might injured to the skull while the baby was born normally, not by axial Cesar, and there might be a fibrome of the uterus or exostosis of the lumbar vertebra. Here's a report in a very long journal, but they found 2 baby that have spontaneous ping pong ball fracture. It can see here that they come to the center of their center in the 1.5 months old. The cause because of probably some natural rotation of the pelvic to first head position, and then last rotation occurred in 2-3 days before delivery. The baby birth in the full term of pregnancy, delivered with first cephalic presentation. The birth weight is normal, is 3 kilograms. Apgar score is good, and then apparently it's in the ultrasonography at 8 months gestation, revealing the depressed skull fracture. And when the baby has already born, you can see here the depressed in the frontal parietal bone. There's the CT scan, and this is after the treatment. And here are some examples of the correction of the depressed fracture that not so invasive. It's safe, not needed any general anesthesia or any anesthesia, and less invasive. It's used the elevation of the breast milk extractor, just like this. They using the Mediva, and there's another report that using do-it-yourself stuff, using the mask and then connected a simple face mask and then connected to the syringe, 15mm syringe, and then it pressed to the side of the depressed, and then make it vacuum and suck it until the bone is come back to the normal form, and it release the compression to the brain. This procedure they usually use in the early 74 hours after birth, and usually after 6 days, the depressed fracture, the ping pong ball fracture, is not resolved. Here is another type of the vacuum correction of the depressed fracture. They use the simple mask and then connected to the macro drip. Here we can see the connected to the micro drip, and then using the 3-way stop clock and connected to the 2 syringe 60mm. And this one can be used for the baby until the 15 days old baby. So it might be longer than the other first one. So here you can see for the bigger baby or for the bigger child, if happen to be depressed fracture or some kind of simple ping pong ball fracture, we could use this technique. We place one burr hole. This one is bigger than the depressed. We can make it smaller, and we can use the distractor, and then we have to put our finger below that, because if we elevate the our tools straightly to the bone, adjacent bone, the adjacent bone would be depressed, have another new depressed under it. So we have to put our finger or another kind of tools, and then we elevate it until the bone is going up to the normal form. It's usually not very normal, but it have less compression to the brain after the elevation. And here our case about the depressed fracture involving the frontal sinus. In the frontal sinus, it's usually we use the most important thing is we do the cranialization to the open air frontal sinus. So we have to strip the mucosa carefully away in the latter two techniques, and in the obliteration and by osteogenesis and cranialization. And the frontal nasal duct is plugs with bone and piece of temporal muscle or fascia, so we can prevent the infection from the nasal air through the frontal sinus, and then the pericranial flap is then layered over this to separate the nasal cavity from the epidural space. Sorry, this is our case, the frontal sinus depressed. You can see that children have a Brill hematome. That's sign of the frontal skull base fracture in the frontal sinus. And we can see here the malformation of the frontal bone, but it's a close depressed fracture. From CT scan, we can see here the frontal bone is depressed, and also it affects to the frontal ethmoidal sinus. And we remove the bone and do the cranialization using the pericranium to protect the epidural space from the infection. And for the depressed fracture to the superior sagittal sinus, we usually find it whether it's open or closed fracture overlay the superior sagittal sinus. If we found it, the bone fracture is torn into the superior sagittal sinus, we can make the burr hole over the cranium a little bit farther from the depressed fracture, and then we open the bone, and then after we can identify the site of the depressed fracture that might hurt the or might lacerated the sinus, we remove the spicules very gently, and then we use the pericranium or fascia to make a neuroplasty overlay the superior sagittal sinus. Then we close again the skull flap tightly, but this is a very tricky procedure. And then plastic neurosurgery technique, usually we can see using the autolog bone, and it's called the reconstructive neurosurgery for treating the defect of the bone depressed fracture bone defect. And then the goal is to provide an intact skull offering for protection of the brain against trauma, and then aesthetic consideration, particularly when dealing with the facial and orbital areas. In the younger and healthy patient with acute and open depressed fracture, we should be replaced the original Calvarian bone after it has been thoroughly cleaned and debrided. Minimal complication and obviates the need for second operation. The benefit is this immediately replacement are quite obvious. Injuries are compound and involve infection are best delayed for 6 months to 1 year to allow the surgical bed to heal and to be free from infection. This one I got from the Professor Goodrich book of the plastic technique of the surgery, neurological surgery. And the several key surgical principles must be kept in mind, that maintenance of the well-vascularized bed and flap, and we have to give a gentle handling of the tissue, and we have to remove all foreign materials, and we have to do the adequate hemostasis. And then the availability of well-vascularized tissue bed without any infection source is absolutely critical to any successful cranioplasty. So the criteria required for successful cranioplasty is clean and well-vascularized bed and flap, removal of retained foreign material, no infection source, avoid the disruption of the regional vascular supply, avoid the parallel scars because of the vascularization is not good if the scars is parallel, and freshen bone edge and remove the retained fibrous tissue. Complete healing of the prior incision, particularly if they are not reused. Here, actually, the most speaker has already speak about the splitting of bone. Here is also the splitting of bone whenever there's defect of the bones because of the depressed skull fracture. We can harvest it from the parietal bone or the healthy bone, and then we do the bone splitting right in the diplo, and then after the bone has already split, is placed into the defect area. Usually using some kind of template, overlay the healthy bone. The template is similar to the or a little bit similar to the bone defect, and then we do it. But sometimes whenever the harvested bone from the donor usually is not well splitted, it's usually we are making the bone chipping, it's okay. We can still put the bone chip over the defect, and then we can do the fixation by PDS suture material, or sometime if there's available for absorbable plate, we do the absorbable plate. But for the
Dr. Sabana, your time is up. If you could finish up.
Sorry. And then from the another materials for the substitute in the bone defect, we can use the bioabsorbable plates, bone substitute or alloplastic material, hydroxyapatite, bone paste and cement, porous polyethylene, computer-aided design technologies such as, and then titanium mesh, methyl methacrylate, and alternate autograft ribs and fibula, and the future craniofacial tissue engineering such stem cell. Here we can see the bone cement that used in the patient that has reconstruction 3 years ago, and then the bone cement has fractured into several pieces. And then here the complication in the infant using the titanium plate or absorbable plate. Also, the plate has migrating to the inner side of the bone. And here we can see the difference between the hydroxyapatite cranioplasty and then porous polyethylene. But since my time is running, so I will. Here is the one is very nowadays famous is bioabsorbable plates, but I usually use this one, but it's not a perfect material too, because of there's an bioabsorbable plate could be leave the contour in the bone after months. So it's not a perfect also for the bone defect repairment. And here is the methyl methacrylate methyl methacrylate complication on the face. It's and then now there's so many pro and cons about the titanium mesh implant that are used in the children. As the previous speaker also talk about this, it apparently that the titanium mesh and implant can be used in the younger child, but in a certain or in a special circumstances. Here is the example, and then this is also the many titanium mesh cranioplasty. It's not they said that the titanium mesh is not recommended for the children under age 3 years old, but in a certain circumstances it could be used. And here also the report that the patient has already placed with their own bone, autologous bone, but it seems that infection, and then they remove the autologous bone and put it in the fridge, in the deep fridge for certain times, and then they put it back, but it seems like the bone is reabsorbed, and then they underwent the resurgery for the patient and use the titanium mesh because the patient is in the school age and has a lot of activity, like he cannot do the school activity, mostly sport, and then the surgeon decide to put the titanium mesh, and there's no complication such infection or allergic reaction for 8 years after the last surgery. we also have our.
Dr. Sabana, we'll have to go to your conclusion slide.
Okay, this is our also the reconstruction in our center using the autologous bone. And our conclusion is the children's skull anatomy is still growing, and it has to be as consideration to choose reconstruction material. The material for reconstruction still on many research and has to be new invention every time. And long-term follow-up is needed for the patient that has underwent the reconstruction, and the bone substitute can be used whenever autologous bone for reconstruction is not possible. Thank you very much. Thank you very much, Professor Kate Drummond. I'm so sorry for the trouble.
No trouble. One interesting question that we had from Dr. Chakrabarty was with regards to the ping pong depressed skull fracture. Do you feel that that would normally resolve spontaneously and maybe doesn't need treatment?
Yes, sometimes it resolves spontaneously, but after we wait for a few days, there's no spontaneous recovery from the ping pong ball. So we do the treatment. If we do the treatment by non-invasive tools and it not work, so we do the open surgery for the correction of the ping pong ball.
And we've got one other question. I'm going to make this the last question. How do you prevent the late infection from open depressed fractures? Particularly, how long do you give intravenous antibiotics after the surgery?
After the surgery, we usually in the unclean, not clean area is open and very dirty wound. We usually use the antibiotics for 3 to 5 days. Then we observe the infection in the clinic.
Thank you. Dr. Chakrabarty's asked me to make some closing remarks, and I'm sure Professor Sinha would like to have something to say, but I'd like to thank him very much for organising this symposium. And I'd very much like to thank all of our speakers. It is really great to hear some different voices presenting at these meetings, and people I've not heard speak before, which is fantastic. Professor Valentini, Dr. Uzuk, Dr. Jagetia, Dr. Simon, Dr. Daba, and Dr. Sabana, thank you so much for your presentations. They were all extremely informative and very useful. Professor Sinha, do you have something you'd like to say before we close?
Same, thanks for giving a good experience or share of our knowledge. Good webinar.
Thank you, everyone, and good night. It's getting late here in Australia. I don't know what the time is everywhere else.
Thank you very much, Professor Sinha and Professor Drummond.
Thank you.
Everyone presented very nicely.
And also
scientific material. And I wanted from youngsters, so they are very good presentation by youngest neurosurgeons. Yeah.
Yes.
Good. We must continue.
Correct.
Thank you.
Good night, everybody.
Thank you very much.
And if anybody wants to see the recording, they can go to the Telegram Academia Neurosurgery group, and they can see the recording, and they can download also, right?
Thank you.
The webinar recording.
Thank you all. Stay safe.
Okay. I will
Thank
email
you.
Okay. Thank you.
Thank you.
Bye.
End for all.